Good evening, chairpersons and my colleagues. This is odd out topic in heart failure, and I think nowadays the non-statin lipid lowering drugs are taking the importance. With this background, how this is useful in our day-to-day practice, I want to share my experiences with the theory background. So the early initiation of PCSK9 monoclonal antibodies in acute coronary syndrome for recurrence risk reduction. So as we know, post-MI, post-ACS period is a vulnerable period for recurrent events. So the cumulative incidence of the events are very high in the first 3 months, almost to the tune of first 1 month 5.3% and at the end of 3 months 7.23%. So, and we also know nearly half of the ACS patients fail to get to achieve the target LDL levels, even after taking sometimes high intensity statin therapy. And the pathogenic mechanisms of the ACS is the vulnerability of the plaque. As we know, the ACS patients, 3 important phases: vulnerable patient, vulnerable plaque, and vulnerable period. If you take the vulnerable plaque, almost the fatty rich plaque with increased protease activity and increased inflammation in the plaques in terms of increased macrophages, all these contributing to the instability of the plaque, which ultimately cause rupture, and is the commonest mechanisms almost to the tune of 70% is the ruptured plaque is the cause for the acute coronary syndromes. And we know the natural history of atherosclerosis, mainly LDLC is the significant contributor towards the buildup of the plaque volume. And not only that one, the small and dense LDL particles are more contributing to this phenomena of plaque growth and fatty rich plaque and vulnerability of plaque, especially because it attracts more and more inflammation, which leads to a thin cap fibroatheroma. And then the Swedish Heart Registry has shown that intensive early and sustained lowering of non-high LDL cholesterol after MI, it will show almost a significant reduction and early as well as sustained reduction of the LDLC, non-HDL cholesterol. And most important is, this is one of the Korean study which was shown the outcomes, cardiovascular outcomes of early LDLC goal achievement in patients with a very high risk ASVD, almost 19% lower frequency and 31% shorter length of stay for cardiovascular related hospitalizations with the early target LDLC achievements. And most important, acute LDLC reduction post ACS, strike early and strike strong is the slogan, from evidence to clinical practice. So in this best case scenario with LDLC assessments and therapy escalations undertaken every 4 to 6 weeks, it might take up to 3 months for a patient to achieve target goals, coinciding with the highest risk period for recurrent events. First 3 months is the most vulnerable period. And this is the ACC, AHA, ACP, NEM, PCSK9i 2025 guidelines in management of patient with acute coronary syndrome. The patient already on maximal intensive therapy, once LDLC is 70 milligrams percent, adding of non-statin lipid lowering is recommended. Whereas the patient, once LDL achieved LDLC 55 to 69, adding of non-statin lipid lowering is reasonable. So with this background, the lipid lowering drugs in acute condition, if you take the application of the PCSK9 early post-ACS phase, on top of the high intensity statin, agitambi therapy lead to more effective and rapid LDLC lowering. If you take the lower, the better. Strike early and strike strong with these regimens of high intensity statins, agitambi, bempedoic acid, then PCSK inhibitors, so that unstable plaque becomes a stable plaque by effective achievement of the target LDLC. And lipid lowering treatment up to 1 year after acute coronary syndrome, guidance from the French expert panel from the implementation of the guideline in practice. If you take rapidly adding during the first 3 months, PCSK9 should be rapidly added, especially in patients with recent acute coronary syndrome because it causes a high vulnerable phase. and patients with recurrent ischemic events under optimal medical therapy, and multivessel coronary disease and polyvascular disease, that means carotids, coronary as well as peripheral, and high risk diabetic, that means diabetes with other comorbid problems, so risk problems, and residual LDL-C above 70 despite maximum tolerated statin therapy and HTMB, and symptomatic peripheral artery disease in diabetic patients. All these are high risk patients where PCSK9 inhibitors and aggressive LDL-C lowering is mandatory. And clinical outcomes of the evolocumab, if you can see, the early LDL-C reduction therapies, if you take evolocumab, almost it will by 7 days 65 to 70% reduction LDL-C you can achieve compared to 12 weeks of HTMB by 12% and bempedoic by 18%, even inclisiran 45%. And the early initiation of evolocumab and cardiovascular outcomes, if you take Chinese patients, this is a study with acute coronary syndrome undergoing percutaneous intervention. Almost the early initiation of evolocumab combined with the statin therapy can significantly reduce LDL-C levels and lower the risk of ischemic cardiovascular events with a good tolerance and satisfactory safety. So both safety and efficacy you can achieve. And even 3 months usage of evolocumab post-PC outcomes, the feasibility, short-term aggressive lipid lowering with PCSK9 acute coronary syndrome. This is a prospective randomized controlled in Japanese study almost showing it is a 3 months therapy of lipid lowering with PCSK9 followed by conventional lipid lowering, or 12 months of conventional lipid lowering. It is almost shown more lower event rate with PCSK9 antibody group compared to the routine without a PCSK9 antibody group. And we know these are the image studies which was showing almost evolocumab stabilizes the plaque by increasing the fibrous cap thickness in thin cap fibroatheromas, especially Hugen's evolocumab and changes in plaque composition. You can observe this is a graphical representation. And then in Glago study with statin, if you take compared to statin monotherapy, statin plus evolocumab reduce the plaque volume significantly. And then plaque regression with short-term usage of evolocumab on coronary fibrous cap thickness by OCT study in ACS also shown that increase in fibrous cap thickness and decrease in macrophages. That means reducing the inflammatory phases and increase the cap thickness were greater with a narrower lipid arc and shorter lipid length, indicating the reduction of the lipid rich plaque converting into low lipid poor plaques, along with the increased fibrous tissue and fibrous cap thickness and reduction of the inflammation. That means converting the unstable to the stable plaque is very high with the PCSK9 with the statin group compared to the monostatin therapy. And even the single shot effectiveness in acute phase with evolocumab, if you can see, and it is a biochemical reduction, almost achievement of LDL-C by 97.7% by reducing the LDL cholesterol and lipoprotein A, as well as the mallaldehyde modified LDL, which is translated in terms of the Ivasini study, which was shown low lipid core burden index from 2015 to 31, it was reduced, indicating that lipid richness, it will reduction of the lipid core in the plaque. And not only this one, evolocumab clinical efficacy, non-HDL parameters along with the LDL-C in terms of reduction of ApoB by 45 to 55%, and lipoprotein A by 25 to 35%, and VLDL-C by 30%, and increase in HDL-C by 5 to 9%. That means other anti-atherogenic lipid parameters also it has a positive impact. And with this background, I want to share one of my practical experience. A vulnerable patient with a young, strong family history with dyslipidemia and vulnerable plaque, and how the management I did. And this is a patient of 25 years old male having non-hypertensive, non-diabetic, non-smoker with a strong family history of CAD, father having MI at 55 years, and paternal aunt having bypass surgery at 56 years. He is a software professional, very high stressed person, usually software professionals are, because time and target oriented. And presenting symptoms are burning chest with sweating with window period of 36 hours, and ECG showing STEMI in inferiolateral leads, and echo showing wall mouth abnormality in the LA territory. And this is the metabolic profile. Total cholesterol is 218 milligrams percent, and LDLC is 198 milligrams percent, and triglycerides 258 milligrams percent, and lipoprotein is 48 milligrams percent with normoglycemic, and thyroid normal, and serum creatinine also 0.8 milligrams with normal liver function test. And this is the baseline angiogram. You can see the right coronary artery normal, whereas the circumflex is non-dominant, and LAD is a type 3 with a lot of thrombi, filling defects in the proximal LAD from ostium LAD to the first diagonal branch, that is a classical proximal segment of LAD. In RAO caudal and LAO caudal showing the similar findings of filling defects, that is thrombi with almost TIMI 2 to TIMI 3 flow with a sticky contrast. You can observe that means a fresh thrombi. And then thrombosuction was done in LAD with export catheter, and then LAD post thrombosuction almost the clots are not there, filling defects are not there, and TIMI 3 flow can achieve with some mild sticky contrast at the LAD diagonal branching point. And CT angio, if you can see classical positive remodeling in the proximal LAD, you can observe this one. Actually, very classical positive, which is a high risk vulnerable plaque in CT angio, allowing the napkin ring, other findings. So these are the other views which is showing a classical positive vulnerable plaque. You can observe the proximal LAD high risk plaque. And normal circumflex and right coronary artery, and then clinical follow-up till 1 year as guideline directed medical treatment post ACS to reduce the vulnerable phase of the ACS of recurrent events. Metoprolol 25 milligrams, prasugrel 10 mg with ecospin 75 milligrams, rosuvastatin 40 mg high dose intense statin, and ezetimibe 10 milligrams, ramipil 5 milligrams, and evolocumab 140 milligrams 2 times a month for 1 year, and follow up every 4 months with lipid profile, random sugars, HbA1c for metabolic health, and the LDLC during follow up is almost 10 milligrams, and lipoprotein A reduced to 5 milligrams. So this is the follow-up angiogram after 1 year. You can see very healthy proximal left anterior artery segment, LAD segment. You can see with the TIMI 3 flow, absolutely a normal human, you can see. And this was supported by means of CT angio 1 year follow-up. You can see very almost the healed LAD you can see from ostium to here, left main. In different views, it is also observed. And OCT we did the study, which is almost showing the mild intimal fibrous thickness with an area of 8.5 square millimeters of diagonal LAD bifurcation and proximal LAD and left main circumflex bifurcation. That means ostium LAD to the bifurcation LAD diagonal. That is a proximal LAD showing absolutely healed plaque with fibrosis. So with this sharing of my experience, the concluding evolocumab in acute coronary syndrome, it is a monoclonal antibody blocking a PCSK9 LDL receptor. So upgradation of the LDL receptors, enhancing the LDL, hepatic LDL clearance, and almost we can achieve LDL reduction by 60% to median to 30 milligrams percent, with MACE reduction of 15% overall and 19% in recent MI. Time to benefit, early benefit almost achieved at 12 months, and it is extending up to 2.2 years with absolute safety profile, well tolerated through 3.2% injection reactions. And key take home message, enhanced ACS benefits almost greatest reduction of 19% with recent MI patients compared to the stable CAD, and aggressive LDL target achievement to the less than 30 milligrams percent, validating the lower is the better in high risk ACS, and early implementation start during the hospitalizations. Some of the practices of cardiologists are within 4 to 6 weeks escalation therapy in the post ACS period to the maximum benefit, and target population high risk ACS on maximum statin therapy with the LDLC more than 70, so that are recurrent events, and almost practical dosing of 140 milligrams twice a month or 420 milligrams monthly injections, monitoring the LDLC at 4 to 12 weeks. I think this is one of the important, especially in young MIs with a strong family history or diabetic, high-risk diabetic population post-ACS. It is mandatory. Aggressive LDL lowering is needed to reduce the recurrent events, to target the high-risk patient, high-risk plaques, and high-risk vulnerable period, so that we can reduce the recurrent events, so that you prevent the ischemic cardiomyopathy in long term, so that ischemic cardiomyopathy associated failures. Thank you.
Brilliant presentation. Only one query. Now inclisiran is also available.
Yes.
So if I say I will give inclisiran 6 monthly over this, will it also perform better? Because inclisiran has also very good results. Another thing, if we are doing elective PCI, multivessel diabetic, will it hold true in that scenario also? Non-ACS scenario, if you want to give right from the beginning after angioplasty.
This is important actually. I think only ACS patients, that vulnerable thing is more important. You have to target so that the recurrent events we can prevent. That is the main target, especially the PCSK9 inhibitors. That is number one. In case of stable CAD, still studies are not there, to be frank. Even inclisiran also after ACS, because the fundamental mechanism of these inclisiran or PCSK9 inhibitors, whether it is a circulating monoclonal antibodies or hepatic PCSK9, it is the conversion of the fatty rich plaques into the stable plaques. That is the main important target, with aggressive lipid lowering to less than 30 milligrams. That is the major thing. Where chronic stable syndromes, you can see that maybe this tight lesion and more plaque volume is the mechanism compared to the ACS, which is the vulnerable plaques. Totally different mechanisms, stable syndromes versus acute coronary syndrome. So this mechanism we have to apply more for the ACS, high vulnerable plaques.
So I want to make two comments.
Please.
One is that now after the racing, Lodestar and all the PCSK9 starting from Improve, it has clearly shown it doesn't matter how you bring down the LDL cholesterol, just bring the LDL cholesterol down is a proven fact, and it's all accepted by all of us.
Yes.
The second point is you're clearly showing that 7 days the PCSK9 starts acting.
Yes.
Orion 1 with inclisiran has shown 40% reduction in 14 days, which is the first trial with the inclisiran. I know that the outcome data is still, but there is a patient level analysis published by Kaushik Ray, which is also published, and outcome is coming next year. So right now we are talking about cholesterol lowering. Just a comment.
Yes.
What are your thoughts on it?
I understand, but as we common sense also, circulating monoclonal antibodies are more effective reduction of LDLC it will do compared to the hepatic PCSK9 inhibitor.
So my question is different for diabetic population.
Yes.
How do you decide which LDL would qualify for these? Because their LDL is low.
Yes, yes.
They are more small, dense, more atherogenic LDL.
Yes.
Otherwise.
This is important. Actually, in Indian, especially lipoprotein is more important. So PCSK inhibitors, the only proven drugs which reduce lipoprotein compared to the statins and azitembe and bempedoic acid. And second important is in diabetic dyslipidemia, especially in Indian population, it is a high triglycerides, low HDL. It is a surrogate marker of increased percentage of small dense LDL. Even though LDL is normal, the percentage of small LDL, dense LDL particles arrive, which are more and more heterogenic, and it will cause more oxidized LDL in the vascular tissue, causing heterogenic plaque progression and fatty rich plaque progression.